So welcome back friends, and here we are to solve this super easy question about the thyroid gland which was posted on the channel. So trust me, it's a very easy question, and even the options are not related to each other, and it is very easy to rule out why it is not something else. So yeah, let's go through the question once. A 30-year-old woman complains that she has had difficulty swallowing along with a feeling of fullness in the anterior neck for the past week. She reports recovering from a mild upper respiratory tract infection 1 month ago. On physical examination, her temperature is 37.4 degrees Celsius, pulse is 74 per minute, respirations are 14 per minute, and blood pressure is 125 by 80 mmHg. Palpation of her diffusely enlarged thyroid gland elicits pain. Lab studies show an increased serum T4 level and decreased TSH level. She is seen by an endocrinologist 2 months later and no longer has these complaints. The free T4 level is now normal. Which of the following conditions is most likely to have produced these findings? So yeah, it is very easy. So let us go through the options. So out of all these 5 options, 3 options, one is medullary carcinoma, toxic MNG, and toxic follicular adenoma. Yeah, all these 3 options, none of them is associated with any sign of inflammation, so we can easily rule out. And also in the history, we have been given a typical history that the patient had a mild upper respiratory tract infection. So looking at all this, it is very easy to rule out that it is not medullary carcinoma, it is not toxic multinodular goiter, and neither it is toxic follicular adenoma, because these are not associated with any sign of inflammation. Then we are left with Hashimoto's thyroiditis. Yes, this is a chronic inflammation. And we are left with DeQuervains thyroiditis. So let us see why this is not Hashimoto's thyroiditis. Because in this question, we've been given that the patient was in a state of transient hyperthyroidism, and now the patient does not have these complaints, and the free T4 level is now normal. So as we all know, what happens in Hashimoto's is that the patient has antibodies. So which are the antibodies? The antibodies are anti-TSH receptor antibody, anti-thyroglobulin antibody, and anti-thyroperoxidase antibody. These are the 3 antibodies a patient of Hashimoto's can have. So these antibodies stimulate the lymphocytes. These lymphocytes enter the gland, they destroy the follicles. The hormone which is stored is released into the circulation, and this phase in Hashimoto's thyroiditis, we call it as hashitoxicosis. It is a phase of hyperthyroidism which we call as hashitoxicosis. So after this, what happens is, since the antibodies are present, they repeatedly keep on stimulating the lymphocytes. These lymphocytes repeatedly enter the gland, they destroy the follicles, and the follicles do not have time to regenerate. So the patient goes in a state of permanent hypothyroidism, since the gland cannot regenerate the follicles. Keep in mind, yes, the thyroid can regenerate. The thyroid has the capacity to regenerate the follicles if it is given time to regenerate. But what is happening in Hashimoto's, it is not getting a chance to regenerate, because the gland is continuously being infiltrated by the lymphocytes, which are continuously being stimulated by the antibodies. And what is happening in DeQuervains thyroiditis is we don't have any antibodies. So after a upper respiratory tract infections, the body assumes that the follicular cells, they have antigens which resemble the viral antigens. So our body thinks that these antigens are also viral antigens, and they attack the follicular cells. So the same thing happens again. The stored hormone is released. Again, a phase of hyperthyroidism is seen. What is happening in DeQuervains thyroiditis is that yes, there is infiltration by the lymphocytes, but this episode occurs only once. Only once the lymphocytes enter the gland, they infiltrate the gland, they destroy the follicles. Again, the stored hormone is released. This all is similar to what happens in Hashimoto's, but since there are no antibodies, there is nothing to repeatedly stimulate the lymphocytes which would enter the gland and keep on destroying the follicles again and again. This thing does not happen in DeQuervains thyroiditis. So if you see the graph, what happens is there is a phase of hyperthyroidism when the stored hormones are released. Then the patient becomes euthyroid, and since there is a state of inflammation in the thyroid gland, so the hormone transiently is not able to produce thyroid hormone. So what is happening is the patient goes into a state of hypothyroidism, but when the inflammation subsides, the patient again returns to a state of euthyroidism. So this is what is happening in what you call DeQuervains thyroiditis. So one of my friends had this question about fever. Why doesn't the patient have fever? So yeah, if you read in the books, what is given is that there are prodromal symptoms like fever, myalgia, malaise, and pain and all. But it is not given in detail in any of the books I read. But what is given, I'll post a link about the research article which I read. It is the Minnesota study which was done about DeQuervains thyroiditis, and it was found out that 96% of the patients present with pain and tenderness on palpation is the most common symptoms with which the patient present. Yeah, there are definitely other symptoms like fever, myalgia, malaise, but yeah, these are also of frequent occurrence, but the most common symptom with which the patient would present, and it is 96% times that the patient is presenting with pain. So yeah, so maybe that is the reason that the patient, our patient does not have a very prominent fever as a symptom. So yeah, definitely the patient would have fever during the phase of thyroiditis and also during the phase of upper respiratory tract infection. So both the phases can have fever, but not always. So yeah, this is why this was DeQuervains thyroiditis. I hope you all understand why this is DeQuervains and not something else. So it was very easy to rule out three of the options, which are toxic MNG, medullary carcinoma, and follicular adenoma. So because these would not have any signs of inflammation, and yes, Hashimoto's is a chronic inflammation, and we've seen why this is not Hashimoto's. So yeah, I hope you all understand. So keep watching these videos, like, subscribe, and share this channel as much as possible. And yeah, stay updated, stay tuned, stay happy, and we'll soon come up with other case scenarios. Thank you.